Bismillahirrahmanirrahim. In this video we will discuss joint tumor and tumor-like conditions, and these are the references for this video. The tumor and tumor-like condition of the joint can be divided into four heads. One is the reactive tumor-like condition, primary neoplasm, which are benign mostly, malignant neoplasm and metastatic carcinomas. The reactive tumor-like lesions are ganglion cyst, synovial cyst and osteochondral loose bodies. The primary neoplasms are rare and usually benign. They tend to recapitulate the cell and tissue which is present over there. If it is arising from synovial membrane, synovioma, fat, lipoma. If it is arising from blood vessel, hemangioma, or if it is arising from fibrous tissue, then it will be termed as fibroma. The malignant tumor is termed as synovial sarcoma, while the metastatic carcinomas are most common, and adenocarcinoma of the colon, breast and lung and the lymphoproliferative disease such as leukemia can occur in this area, and they mimic other conditions such as rheumatoid arthritis. The word ganglion is a Greek word and it means knot. Though it is named as ganglion cyst, it is unrelated to ganglia of the nervous system. The ganglion cyst is a small fluid-filled cyst up to 1.5 centimeter and it contains clear mucinous fluid. It is common in women between the age of 25 to 45 years, and it is nearly always located near a joint capsule or tendon sheet, most commonly on the extensor surface of the hands and feet. They develop due to cystic or myxoid connective tissue degeneration. Hence, the cyst wall has no lining. Morphology, it is a firm, fluctuant, pea-sized, translucent nodule. It may be multilocular and can enlarge through coalescence and degeneration of the adjacent connective tissue. The cystic fluid nature is similar to the synovial fluid, but there is no communication with the joint space. The treatment for this ganglion cyst is the surgery, and there is another traditional treatment in which blow with a family Bible was made to treat the ganglion cyst on the dorsum of the wrist. The left picture is showing the typical location of the ganglion cyst, and this is usually located on the dorsum of the hand, while this right picture is showing the cut surface of the ganglion cyst, which is showing that this firm translucent cyst is filled with clear mucinous fluid. This photomicrograph is showing the histopathological appearance of a ganglion cyst, which is showing that the cyst wall is composed of dense connective tissue with areas of myxoid degeneration, while the lining epithelium is flattened, or it can be devoid of any lining epithelium. The synovial cyst is the herniation of the synovium through a joint capsule or massive enlargement of a bursa may produce a synovial cyst. It is associated with arthritis in which joint pressure is increased. These synovial cysts are lined by epithelium which resembles synovium, and both the cyst and the synovium may be hyperplastic. The cystic fluid is usually inflammatory cell and fibrin containing. Then there is a term that is Baker cyst, and this Baker cyst is named after the scientist who described this lesion. And this is the herniation of the synovium of the knee joint into the popliteal space, as it is shown in this picture. The associated lesion of this Baker cyst are rheumatoid arthritis, the degenerative joint disease, or Charcot joints. This is a MRI, and it is showing on sagittal section that there is a popliteal or Baker cyst, which is marked by this red arrow, and this is posterior to the medial condyle and represented as collection of fluid. The inflammation of a bursa is termed as bursitis. The bursae are synovial sacs, and these are found over moni prominences. The bursitis occur following mechanical trauma or inflammation. These bursitis can occur following a single injury, as occur in olecranon bursitis and prepatellar bursitis, but the more common one are the repeated injury, which occur in as housemaid's knee and tennis elbow, in which there is repeated injury to these bursae. Then the gross appearance of these bursitis: the sac is thick-walled and may contain watery mucoid or granular brown material. Then on the microscopy, the thick wall is fibrous and is lined by the inflammatory granulation tissue. There is abundance of the lymphocytes, plasma cell and macrophages, and there can be deposition of calcium. A related injury is subdeltoid bursitis with calcareal tendinitis. That is degeneration of a tendon or muscle in rotator cuff of shoulder with subsequent calcium deposition in necrotic collagenous tissue. There is a secondary inflammation due to this calcific material. So this is the gross appearance of a bursitis in right elbow. This is a fluctuant, tender and slightly red swelling of the right elbow, and this condition is also termed as tennis elbow. The synovial osteochondromatosis is a controversial lesion, as some scientists consider this lesion as a reactive lesion, while some consider it as a benign tumor, because it is associated with dysregulation of hedgehog signaling in experimental model. This disease is a benign self-limited disease in which hyaline cartilage nodule form in the synovium. They detach from the structure and float within the synovial fluid. The loose bodies will result in chronic irritation, and the synovium is stimulated to secrete large amount of the synovial fluid. There may be bleeding within the synovial membrane. The commonly affected age group is young and middle-aged men, and the most common site involved is knee. However, the hip, elbow, shoulder, ankle and temporomandibular joints are also affected. They present with pain, stiffness and locking of the joint. Blood effusion can also be seen. We have seen that the osteoarthritis is also associated with the presence of cartilage fragment within the joint space, but this entity differs from the cartilage fragment which is present in osteoarthritis, in that the fragment of the hyaline cartilage which is present in the osteochondromatosis is formed within the synovium de novo, and there is no tide mark is present as it is seen in the cartilage of the joint. And if this fragment of the cartilage undergo endochondral ossification, it will result in synovial osteochondromatosis. When it is detached from the synovium, the bony portion of this fragment will undergo necrosis, while the cartilage fragment will remain viable and enlarge, as cartilage derives its nutrition from the synovial fluid. The treatment is joint evacuation and synovectomy. It recurs in 15 to 20% cases, but malignant transformation is rare. So this X-ray of the knee joint is showing the nodules within the joint space. This is the gross appearance of the synovium in this osteochondromatosis, which is showing that there is extensive involvement of the synovium and presence of these irregular small cartilaginous fragment. This is the histopathological appearance of the synovial osteochondromatosis, which is showing this biopsy is showing that there is presence of nodules of benign hyaline cartilage which are present within the synovium. So this is another example of this synovial osteochondromatosis. This is showing that there is calcification, foci of calcification within this hyaline cartilage, which is present within the synovium. It is necessary to diagnose this condition. It is necessary to isolate this hyaline cartilage both from the synovium and from the joint space, as if these are only present within the joint space. It is a common feature of osteochondritis dissecans and neuropathic joint. Besides dysregulation in the Hedgehog signaling, some of the cases of this synovial osteochondromatosis have shown chromosomal 5 extra copies, 6 anomalies, and rearrangement in the short arm of the chromosome 1. The tenosynovial giant cell tumor is the most common neoplasm of the synovium, tendon sheath, and bursae. This lesion may be intra-articular or extra-articular, and it occurs in two forms, a localized form and a diffuse form. The localized form is also termed as giant cell tumor of the tendon sheath, and it involves the hand and feet. In fact, it is the most common soft tissue tumor of the hand. It affects young and middle-aged women between the age of 30 and 50 years, and commonly it is present in the flexor surfaces of the middle and index finger. The tumor is usually well circumscribed, and it grows slowly. While the diffuse form of the tenosynovial giant cell tumor was previously termed as pigmented villonodular synovitis, it is monoarticular, affects young adult, and it is the frequency is equal in both genders. It affects the knee in about 80% of the cases. However, hip, ankle, calcaneocuboid joint, elbow, and less frequently the tendon sheath of the finger and toes are also affected. The diffuse form is ill-defined exuberant proliferation of the synovial lining cell arising from the periarticular soft tissue with extension into the subsynovial tissue. So previously this tenosynovial giant cell tumor was also considered a reactive lesion, but after the observation of some chromosomal changes in this lesion, it is now considered that it is a tumor. It is associated with the somatic chromosomal translocations in chromosomal 1 and 2. There is fusion of the type 6 collagen alpha 3 promoter upstream of the coding sequence of the macrophage colony stimulating factor gene, and due to this fusion there is increased expression of the macrophage colony stimulating factor, which is responsible for the proliferation of macrophages, which produce lesions similar to the giant cell tumor of the bone. The only diffuse form is associated with trisomies of the chromosomes 5 and 7. The localized form of this synovial giant cell tumor is an exophytic mass attached to a tangent sheet, and this mass is small in size and it is usually less than 4 cm, multinodular, smooth contoured and partially encapsulated, while the diffuse form is more than 5 cm in measurement. It is also poorly circumscribed, but it is red brown to orange in appearance. It invades the joint and erodes the bone also, and this lesion may insinuate through the joint capsule into the surrounding soft tissue and encompass nerve and arteries which are present there. Hence this lesion requires radical surgical excision. The synovium develops enlarged fold and nodular excrescences, and these are brown in color due to iron pigment content. The microscopy for both the localized and diffuse form are same. The neoplastic lesions, which are present in a small number in the mass, are polygonal. They are moderately sized and they resemble synoviocytes. A solid aggregate may be attached to the synovium by a pedicle, and these are densely infiltrated by macrophages that may contain hemosiderin or phospholipids and can be multinucleated. The diffuse form infiltrates extensively into the surrounding tissue and shows a villous configuration. The outer lesions are fibrotic. So this picture is showing the gross appearance of tenosynovial giant cell tumor, which is a small solid tumor with brown cast. The brown cast is due to the hemosiderin. This is the whole mount of localized form of tenosynovial giant cell tumor, showing lobulated appearance of the lesion. This is the histopathological appearance of tenosynovial giant cell tumor, which is showing that there is dense fibrous tissue with polymorphic infiltrate of small histiocytes and multinuclear giant cell. This is the radiological appearance of the tenosynovial giant cell tumor, diffuse form, which is showing that there is a soft tissue mass within the joint and confluent erosion of the distal femur and proximal tibia. This is the gross appearance of the diffuse form of tenosynovial giant cell tumor. There is massive destruction of the femoral condyles. The surface is nodular and brown in color. It is looking like a tangled mat due to these brownish folds. This gross picture of the excised synovium is more precisely representing the tangled mat appearance of tenosynovial giant cell tumor. This is the histopathological appearance of the tenosynovial giant cell tumor, which is showing that the synovium is thickened and showing villous architecture. This is the histopathological appearance of the diffuse form of the tenosynovial giant cell tumor, which is showing that below the synovium there is sheet of proliferating cells, and these cells are bulging toward the synovial lining, and hence it is responsible for the nodular appearance. While looking closely under higher magnification, these cellular infiltrate consist of mononuclear histiocytic synoviocytes, many of which contain brownish hemosiderin pigment, as it is evident in this picture. and there is presence of multinucleated giant cells. Some foci within this diffuse tenosynovial giant cell tumor also show foamy cells aggregate. So this diffuse tenosynovial giant cell tumor is characterized by infiltrates of a small oval to spindles histiocyte with the numerous interspersed multinucleated giant cell, and these are present in a background of fibrous tissue. So the patient complain of pain, locking of the joint and recurrent swelling of the joint, and most of the symptoms are similar to the monoarticular arthritis. There can be a palpable mass also. The localized form is characterized by presence of a solitary slow growing painless mass that frequently involve the tendon sheet along the wrist and finger. Bone erosions are less common in localized form, while diffuse form is characterized by presence of an aggressive tumor that erode into the soft tissue and adjacent bone, and it should be differentiated from the other tumors which are present in this area. The treatment for the tenosynovial giant cell tumor is use of antagonist of macrophage colony stimulating factor signaling, or surgery is another treatment modality, and radiation can be used for the cases in which the tumor cannot be excised. The recurrence rate is less for the local one, and it is about 40 to 50% in the diffuse forms of tenosynovial giant cell tumor. The other common tumor in this area is synovial hemangioma, which is a tumor of young male. The commonly involved site is knee, but it can be seen in elbow and finger. It involves commonly the synovium, especially the intra-articular synovium, and less commonly it involves bursa. The microscopic appearance of this synovial hemangioma is lobular capillary hemangioma, while arteriovenous hemangioma and venous hemangioma can also be. The synovial sarcoma is grouped with soft tissue tumor and comprises of about 10% of all soft tissue sarcomas. Despite its name, it's neither arise from nor it shows any synovial differentiation. It got this name as first case of the synovial sarcoma arose in soft tissue near the knee joint, which led to the presumptive relation of this lesion with the synovium. However, this lesion can be present in location that lack synovium. So we can define this entity as a highly malignant soft tissue tumor characterized by the translocation between chromosome X and 18. They may arise anywhere in the body but are commonly located in the deep soft tissues near joint tendon sheet or joint capsule. The lesion is present in the patient between the age of 20 to 40, and it's a deep-seated mass that has been present for several years. Knee, ankle, shoulder and hip are affected, but these tumors can also be seen in neck, anterior abdominal cavity, retroperitoneum, mediastinum, blood vessels and nerves. Some cases of this synovial sarcoma are also reported in oral cavity, salivary gland, lung, gastrointestinal tract, kidney, prostate and vulva. More than 90% cases of the synovial sarcoma are associated with the translocation between chromosome X and 18. The SS18 gene is fused with SSX gene. The SS18 gene was previously known as SYT gene. The fusion of these two genes will result in the production of a chimeric protein which interferes with the normal chromatin remodeling. There is the repositioning of the nucleosomes on the chromatin that influences the gene expression is disturbed, and there are three types of the chimeric protein are present usually. SSX18, SSX1, which is the commonest one, present about 2/3 of the cases, and it is present, it is morphologically presented as a biphasic pattern. And the SS18 SSX2 gene or chimeric protein is associated with the better prognosis, and in this variety the morphology is monophasic, while the SS18 SSX4 protein is a rare one. There is expression of TLE1 transcription factor or transducin like enhancer protein 1 is also associated with this synovial sarcoma. This TLE1 or transducin like enhancer protein is a transcription factor which is associated with cell fate determination. It is characteristic and may account for the dual epithelium and mesenchymal differentiation in synovial sarcoma. The transducin-like enhancer protein is a co-repressor that inhibit Wnt signaling, hence affect the differentiation. This picture is describing the gross appearance of the synovial sarcoma, which is a circumscribed round to multilobular mass attached to the tendon sheet or exterior wall of the joint capsule. These nodules can be small or masses of about 15 centimeter or maybe more in diameter. The average size is about 3 to 5 centimeter. The tumor is surrounded by a glistening pseudocapsule, and in some instances it may become cystic in appearance. There may be areas of hemorrhage, necrosis and calcification. This is a deep-seated synovial sarcoma involving periosteum of the femur. It is a well circumscribed, firm, grayish-pink lesion with foci of calcification. The synovial sarcoma on histology is characterized by two patterns. One is monophasic pattern and another is the biphasic pattern. The monophasic pattern of the synovial sarcoma consists of the uniform spindle cells with scant cytoplasm and dense chromatin arranged in short, tightly packed fascicles, and they give characteristic school of fish appearance in which the cells are arranged haphazardly and parallel to each other. The biphasic pattern of this synovial sarcoma represent as fluid-filled glandular spaces which are lined by epithelial-like tumor cells, and these epithelial-like tumor cell-lined glandular spaces are embedded in a sarcomatous spindle cell background. Both these two elements vary in proportion, distribution and cellular differentiation, with the spindle cells usually considerably more numerous than the glandular element. In both types, the calcification may be seen, and the tumor cells are positive for the cytokeratin and epithelial membrane antigen on immunohistochemistry. This photomicrograph is showing the school of fish appearance of the monophasic pattern of the synovial sarcoma. There are swirling fascicles of plump spindle shaped cells with monomorphic hyperchromatic nuclei. This is the high power view of the same monophasic synovial sarcoma, which is more clearly showing the swirling fascicles of plump spindle cells. The presence of mast cell in the monophasic synovial sarcoma is an important diagnostic clue for the synovial sarcoma, and these are stained by toluidine blue. This photomicrograph is showing the characteristic biphasic appearance of the synovial sarcoma, which is showing the gland-like space lined by the malignant cell, and on the upper left side of this photomicrograph there is spindle cell population. Sometimes these glandular spaces, which are lined by the malignant cells, they exhibit proteinaceous material within the lumen, while you can see that there is abundance of the spindle cells in the background. The biphasic pattern is characterized by epithelial and mesenchymal sarcomatous component, but these terms are descriptive only. They are not reflecting the histogenesis of these cells. This photomicrograph is showing the synovial sarcoma with an adenocarcinoma-like appearance of the epithelial component. In synovial sarcoma, there can be associated hyalinization, calcification, or osseous metaplasia. When there is heavy calcification present, it is termed as calcifying synovial sarcoma. This is the radiological appearance of calcifying synovial sarcoma in the popliteal space. So this is the synovial sarcoma, which is showing the calcifying lesion within this biphasic pattern. So this is termed as calcifying synovial sarcoma, and the osteoid and bone formation can be so extensive that it obscures the true nature of the tumor sometimes. The recurrence rate for the synovial sarcoma is high. More than 60% cases metastasize, and they go to the lung and regional lymph node in 15% of the cases. The treatment of this lesion is limb sparing surgery and high dose of radiation therapy, and the 5-year survival varies between 25 to 62%, and it is dependent on variety of factors. One is the calcification. If there is calcification, the prognosis is good and survival is about 80%, and the prognosis is good in younger age. If it is located distally, the prognosis is better. The prognosis is better if the size is less than 5 cm and surgical margins are free. The mitosis is also another factor for the prognosis. If the mitosis are less than 15 per high power field, it is associated with good prognosis. If necrosis is present, it is associated with worse prognosis. Presence of rhabdoid cell, dysadherin expression, and aneuploid tumors are associated with worse prognosis also. The synovial chondrosarcoma is a rare entity, closely resembles with synovial chondromatosis grossly and radiologically. The obvious histological features of malignancy are seen on biopsy, while morphologically this lesion has a more expansile quality than the usual synovial osteochondromatosis. So we can summarize the tumor and tumor-like lesion of the joint into some categories. One is the reactive tumor-like condition, or benign tumor or malignant tumor. The reactive tumor-like conditions are ganglion cyst and synovial cyst, while the other lesions are some inflammatory lesion such as bursitis, synovial chondromatosis, or nodular fasciitis. The benign tumors of this region are tenosynovial giant cell tumor, both the localized and diffuse one, and the synovial hemangioma. The malignant tumors of this joint are synovial sarcoma, intra-articular hemangiopericytoma, intracapsular chondroma, epithelioid sarcoma, arthroplasty associated malignant fibrous histiocytoma, and malignant lymphoma.